Welcome, everyone, to the 2024 American Cancer Society National HPV Vaccination Roundtable meeting. I'm Dr. Heather Brandt. I direct the HPV Cancer Prevention Program at St. Jude Children's Research Hospital. I serve on the steering committee, and later this month will conclude my service as chair of the Best Practices Task Group. So this week, we have been celebrating 10 years of the ACS National Roundtable, and I hope you've been able to join us for the earlier sessions this week. I know all of you join me in saying thank you to the National Roundtable and team and members on 10 productive, impactful years. I remember being at the first meeting of the National HPV Vaccination Roundtable in Atlanta 10 years ago and wondering how the story would unfold. And here we are today. So today is our final day, and we plan to keep the celebration going. So please get out your party hats and prepare to be inspired by the global HPV vaccination work today. So a few housekeeping items before we get started. So throughout the session today, please post any comments, reactions, or needs in the chat. And any questions you have for the speakers, please use the question and answers box or the Q&A box there in the bottom toolbar. And the approved presentations and a recording of today's session will be shared. So please subscribe to the National Roundtable newsletter via the website and their socials for more information on new resources, videos, and a lot more. We don't want to overwhelm the amazing Roundtable team, but let's say thank you to them in the chat. Let's give them some praise and thanks for bringing all of us together around this very important topic of HPV vaccination. And before we dive into today's session on global best practices in HPV vaccination, we want to thank all of you as well and everyone that's helped us build this work over the last 10 years. This celebration really is for all of us. So today we're exploring these global best practices in HPV vaccination, and we are starting with a celebration of the ACS National HPV Vaccination Roundtable, next slide, by hearing from Dr. Noel Brewer, the inaugural chair of the Roundtable. So then we'll hear from three presenters, including Dr. Kaja Abbas, Dr. Joel Palevsky, and Sarah Comstock. So after their presentations, we'll have time for questions and answers. And we'll end with a call to action for the after party to conclude our celebration today. So don't forget, drop your thank yous to this amazing team and everyone who's been part of the last 10 years in the chat. All right, let's hear from the interview with Dr. Brewer. I'm Heather Brandt, and I direct the St. Jude HPV Cancer Prevention Program and serve as a member of the National Roundtable Steering Committee and as chair of the Best Practices Task Group. And it's truly my privilege today to interview Dr. Noel Brewer, who is the Gillings Distinguished Professor in Public Health at the University of North Carolina at Chapel Hill, and one of the earliest thought leaders and supporters of the National Roundtable. So let's get started. So Noel, tell us about your current work and your career with HPV vaccination.
So my work on HPV vaccination started with a grant from CDC to understand who's getting HPV vaccine and why, HPV vaccine and why. And so this was back in 2006. So I had the luxury of working with Lori Markowitz way back in the day and then others at CDC, and they helped me change my thinking about HPV vaccine. Originally, my thoughts were more along the lines that it was about what people thought, what their opinions were. And I came to increasingly appreciate that it had to do with basic things like access and ensuring that a provider was recommending the vaccine. In terms of what I'm doing these days, we have a large center grant that allows us to do several trials at the same time. One of them is on standing orders for HPV vaccination, understanding their impact. another one on financial incentives led by Justin Trogdon, and then a final one on the use of champions, vaccine champions, yet led by Melissa Gilkey. And then we're doing a cost effectiveness analysis that ties all this together, led by Stephanie Wheeler and Satya Ozawa.
Great. And certainly the contributions of you and your collaborators have informed so much of the work that's happening today in HPV vaccination. So tell us, what keeps you so passionate or fueled to do this work?
I think all of our energies come and go. So there are times when we have more energy for something and a little less, and I've certainly had that happen in this area. But we have a vaccine that's effective at preventing cancers, and not just a cancer here or there. Thousands of cancers every year are preventable by the vaccine. That's a big deal. My mom died from cervical cancer, and I'm convinced that she'd still be with us today, and she would have met her grandchildren if the vaccine had been around when she was a girl.
Thank you for sharing that very personal connection that certainly has to be top of mind for you in this work. So, being the founding chair of the National HPV Vaccination Roundtable, tell us more about your experience bringing the current roundtable to us and what you see as highlights over the last 10 years.
I mean, it started out as just Debbie Saslow having written a grant, and her and an admin assistant just trying to pull everything together. And it was not an easy process, because it was just having to make everything up, creating bylaws, creating ways that we got together, dreaming up what a national meeting would be, where we brought everyone together, trying to figure out what is it that we were even trying to do. Do we convene people? Are we supposed to be giving grants? Are we doing research? Are we more being thought leaders and trying to catalyze the efforts that people are doing? So some of those ideas of convening and catalyzing and so on came along through the years. One of the highest praises that I heard once was from a colleague at the National Cancer Institute who was visiting and said, wow, there's really a focus here now that's developed over time. And I think that's true. I think early on, the roundtable was just about everything all at once. Let's go. We got to do it. Let's go. Let's go. And then increasingly, we realized that it's time to be more strategic and focus on some initiatives more than others.
And I think back to that first meeting when so many of us gathered 10 years ago in Atlanta to begin these conversations. And at that time, I remember thinking, I'm not really sure what this is going to be, but I like it. I looked around the room and I liked the energy. I liked who was there, the partners represented. So, what do you think has been the greatest achievement of the roundtable to date?
The roundtable has increasingly engaged thought leaders and senior folks in making change in their organization and through their organization. It also includes the rank and file, and I consider myself kind of in that way as well here at UNC, and helping us in our middle management place, or in our whatever the role is that we occupy, trying to figure out how we can enact change as well. How do we nudge the leaders in our organizations along? So that's one of the biggest changes in the roundtable over the years, is shifting our focus from sharing information and talking at people, and maybe even having people talk with one another, and shifting towards trying to get people to understand what change they could make through their organizations to make a change in HPV vaccine uptake.
And so, how do you see the roundtable as having facilitated that? Is it just a product of throwing all of us together, or what do you see as kind of that secret sauce that's really led to that development?
I think it's one of the earlier things was us realizing that we needed to do it. And I was saying it in a sort of a roundabout way, but at some point, I think it was Melinda Wharton from CDC who asked her the question point blank: how does this turn into action? How do we get people here to change their behavior so we can actually see an impact? And so that led us to make that one of the goals of the national meeting, one of the goals of our evaluation, one of the goals of our follow-up, one of the goals of our interaction with different organizations as the roundtable, to try to figure out what are the behaviors that a person at a cancer advocacy organization can do. What about the folks who are representing physicians? What about the folks who are part of a nursing organization? What about folks who are representing cancer survivors? How can each of these different kinds of organizations and different kinds of people each take an action that will cause change?
Right. So what do you envision for the roundtable in the next 10 years?
Well, I think one of the big challenges, and I hope you can see that I'm smiling as I'm saying this, is that it will have to continue to exist. So it needs to retain its funding in some way, and to do that, it needs to demonstrate value. So that's
Hmm.
the most important thing that the roundtable will have to do over time. I do think it's a valuable organization. I do think they're creating value, but they're going to have to continue to say that. And it's hard when your outcome is catalyzing people to action. It's a little bit different when you're building capacity in that way.
Hmm.
It's also true that at some point, the nation will go to a one-dose schedule. It's very likely. Who knows
Hmm.
when? Maybe sooner, maybe later. I think it's sooner, but
Hmm.
that's unknown. But when we go to a one-dose schedule, all of a sudden the really low HPV vaccination rates will be a little low, not a lot low.
Hmm.
So vaccine completion for 2 doses we're really low on. But once you start talking about single dose HPV vaccine initiation, we're going to be talking about 75% instead of 84%, that kind of a comparison. And those are really different kinds of problems to solve. So as we look forward, I think we have to be especially engaged in places where HPV vaccination is very low. So that
Hmm.
will mean geographic differences are going to be particularly important. There are some states with extremely low rates, like Mississippi, for example. And at the same time, they're low for a reason. It's hard to do work there. They've got a lot going on. They're doing a lot with a little. It's true of many areas that have larger rural populations, they have lower rates. And it's because there's just a different public health and
Hmm.
care infrastructure. So we have to figure out, what does engagement look like that helps the people who are there in those places doing the good work? How can we make their jobs easier?
Hmm.
Not how do we make them harder by partnering with us? How does partnering with us raise HPV vaccination rates and at the same time make their job maybe a little bit easier?
So I think you gave us a little insight into your thinking here, but it's been 18 years in the United States and we still see low up-to-date coverage. So what is stopping us from protecting kids today from HPV cancers they may develop in the future?
One thing is that we don't have command and control. Primary care is very disseminated. It's done in a lot of different ways in a lot of different places. And we don't even have centralized data so much. So
Hmm.
I'm not saying that centralization is a good thing necessarily, but it has consequences for trying to enact change. That's one piece of it. A second piece is our main folks, the folks who are really at the front lines, are all the primary care providers and nurses. All those folks who are helping teens and adolescents and even children ages 9 and 10 to get whatever care they're going to get, and also HPV vaccine. Those are the folks we need to work with.
Hmm.
They are swamped.
Hmm.
As a result of the pandemic and other changes, centralization in healthcare, the way that reimbursement works and so on, a lot of people have left medicine. My own
Hmm.
primary care physician left after 10 years because she was just done with it. She's like, this
Hmm.
is no fun anymore. And I totally get it. So folks who are still there, still fighting the good fight, providing outstanding care, we have to help them not get burned out. And then
Hmm.
also help them find room in their day to focus on one more thing. And the
Hmm.
ideal situation is to do it in a way where it makes it easier, not harder for them.
Well, thank you. And so to close, I want to move to sort of a lightning round to get just a few quick questions and answers from you. So first, what's your favorite food?
Right now, it's this Middle Eastern, it's kind of like a yogurt. It's called labna. So I have it
Excellent.
every day at lunch.
What is the best part of your day?
The morning walk to coffee.
What's your
There are no
favorite
kids.
what's your favorite TikTok genre?
Okay, this is hard to describe it. Okay, it's depressed frontier lesbian TikTok, where there's like a woman who's like, she's in Maine. Her water heater has gone out. She's out there, literally, she's lit a fire in her with her bare hands, and she's talking in a monotone. And I'm like, I want to be her. She's so amazing.
I love it. What famous person, dead or alive, would you like to have lunch with?
I'm not sure. I think it might be Tressie McMillan Cottom, who's a Genius Award
Mhm.
recipient and just all around
Yes.
extraordinary person, often New York Times columnist and a scientist here at UNC. Or maybe Harriet Tubman, who Bob the drag queen once described as the first Black superhero. I would love to meet her, and hopefully I would be not a nuisance to either of them because I think I'd learn a lot.
Excellent. And what's something about yourself that you're willing to share that might surprise us?
I'm a high school dropout. I never graduated. I'm a college dropout. I actually had to go back to get a degree to do the other things I wanted. But yeah, it's like what one of the Bushes said, if you get a C, if you're a C average, you too can be president one day. So, whatever your background is, whatever your history, there are opportunities in front of us.
Oh, that's great. Well, thank you, Noel, for this interview, but most importantly, thank you for your tremendous contributions to vaccine decision making and specifically our efforts to improve HPV cancer prevention and this national roundtable. You're truly a bastion for good science, catalyst for change, and inspiration for so many of us. So much appreciation and thank you.
Thank you so much for that. And also, and I'm blushing, but thank you, Heather, for your leadership. It has been really important. All the work that St. Jude is doing has really made a tremendous difference in this area. Thank you.
Thank you. All right. I hope you all enjoyed my interview with Dr. Brewer. It was always wonderful to talk with him. So today we're joined by three amazing presenters. First, we're going to hear from Dr. Kaja Abbas from the London School of Hygiene and Tropical Medicine in the Nagasaki University in Japan. Then we'll hear from Dr. Joel Polewski from the University of California, San Francisco. And lastly, we'll hear from Sarah Comstock with the American Cancer Society. So let me turn things over to you, Dr. Abbas.
Hello, everyone. It's my pleasure to present all of you. This is definitely a much fun group than the typical academic audience that I normally present to. And just please call me Kaja anytime later for any questions or any comments. So what we like to focus on is just to understand. We understand the HPV vaccine is beneficial, but how much benefits do we actually gain from HPV vaccine? And then these vaccines do cost. So what is the cost of these vaccination programs? And also, is this an equitable intervention? Like, do all adolescent girls who need it are able to get it? And then now with the extension of the vaccine from girls to also to include boys, this gender neutral program is able to reach all eligible girls and boys as much as possible. And you look at some of those discrepancies in different parts of the world. Next slide, please. Yeah, please, next slide. Yeah, okay. So the current burden as it stands today is that still more than 660,000 new cases of cervical cancer occur across the world, and then almost 350,000 women die from cervical cancer globally, of which the main affected areas are primarily in Asia, and that's primarily driven by the large demography as well. But another area that's severely affected is also in Africa as well, wherein among the women who are basically getting the new cases that we see around 125,000 cases, but also we see a very large burden who actually result in mortality, almost 80,000 women in Africa dying from cervical cancer. And this has got to do with not necessarily the high risk of HPV infection, but more to do with access to quality healthcare, which is especially limited for like secondary and tertiary treatment for cervical cancer in these resource-limited settings. But we have had vaccines since 2006, the bivalent and quadrivalent vaccine, which protects against the high-risk HPV 16 and 17, which accounts for nearly 70% of all cervical cancer burden. And for the last 10 years, we have also had the nonavalent vaccine, which prevents further almost another 20% of the cervical cancer burden, for a total of almost 90% of all cervical cancer can be prevented by the nonavalent vaccine, which is currently now available in the US as well. Next slide, please. But the vaccine in itself does not necessarily result in vaccination uptake. And to understand the rates, how to provide the vaccine, we need to understand the current burden of cervical cancer, the public health benefits, like quantifiable benefits of vaccination, the stakeholders' acceptability. For example, currently in the US, the vaccine is provided as a 2-dose program, while some countries, the stakeholders have moved on to a 1-dose program as well, while there are still some countries with a 3-dose program as well, such as Japan. Sorry. Also looking at the cost effectiveness of the vaccination, the equitable impact of the vaccination, whether we have the infrastructure to provide these vaccines, the cold chain infrastructure, so whether it's a feasible intervention or not. And last but not the least, while these aspects are focused on the supply side of the vaccine, also what is important is also look at the demand side with respect to the vaccine confidence, what levels of vaccine hesitancy you have, so that it can lead to much higher uptake of the vaccine. So there are several factors that needs to come together in order to have a successful vaccine program. Next slide, please. So when Tedros did take over as the WHO Director General, one of the key signature programs that he developed is a cervical cancer elimination strategy, wherein we would like to eliminate cervical cancer as a public health problem by the end of the century. And there are 3 key interventions that are currently available. One is the vaccine, another is a screening test, but beyond the screening test, we also need to provide treatment that can potentially clear all the pre-cancer lesions. And also for new cases that are diagnosed, able to provide quality treatment and care. While we like to reach high coverage, around 90% coverage for vaccination, 70% for coverage for cervical screening and treatment if needed, and around 90% coverage for cervical cancer diagnosed women, among these 3 interventions, the most feasible intervention is the vaccine program. Because if you do provide cervical screening and if it needs follow-up treatment, that needs highly skilled healthcare personnel to do it. And same thing for treatment of cervical cancer diagnosed women. We need high quality physicians, clinicians who are able to provide that kind of care, which is quite limited in most places around the world, wherein it really underlies the significance of the vaccine program to be scaled up so that we can prevent these cases occurring in the first place. Next slide, please. So in order to model the impact of the vaccine, we use a tool which we refer to as the PRIME tool, which is the Papillomavirus Rapid Interface for Modeling Economics, wherein we look at the current burden of cervical cancer. And then depending upon the coverage that we can attain with the vaccine program, and what kind of vaccine is it? Is it a bivalent, quadrivalent, or a non-valent vaccine? Like a non-valent vaccine can prevent up to 90% of all cervical cancer, while a bivalent or a quadrivalent vaccine will protect against up to 70% of all cervical cancer. And then looking at what level of coverage we can attain. Thereby, we can actually estimate by age what will be the proportional reduction in burden in cervical cancer across the life course of all the women. And the vaccine has the highest efficacy if it is given pre-sexual debut, which is why it's recommended to be given from ages of 9. And in the case of the US, we recommend between ages of 11 and 12 as well. And so correspondingly, once we can estimate this burden, we can estimate this burden with respect to how many cases can we avert, how many deaths can we avert, and how many healthy life years can we gain by providing this vaccine program. Next slide, please. And when we do estimate it, what we do see is that countries in the African region actually stand to gain the most for every 1,000 vaccinated girls, while countries in the Eastern Mediterranean region, relatively speaking, stand to gain the least from the vaccine. And when we look at the map again, as we can see, again in the sub-Saharan African countries, the cervical cancer burden is much higher per 100,000 women. Thereby, these are the countries that should be prioritized for the vaccine introduction. But what has happened is kind of the flip-off side of it. Countries like UK and the US were among the first countries to introduce the vaccine, even though relatively speaking, the burden of cervical cancer is relatively lower in these countries. So we had this kind of an inequitable introduction of the HPV vaccine across most countries to date. Next slide, please. And with respect to estimate efficiency, we look at the resources that we put into the HPV vaccine program, but then there's also a gain with respect to reduction in treatment costs because of the reduced number of cancer cases. But then this net cost of our HPV vaccine program, if you put it in the current health system, we can gain a number of healthy life years. In comparison, the number of healthy life years that we gain from the HPV vaccine program must be much higher than investing those resources in the current health system. Or in essence, our net health impact should be positive with introduction of the HPV vaccine program. Next slide, please. And here, with respect to Gavi, the Vaccine Alliance provides affordable access to lots of childhood vaccines, including HPV vaccines in low-resource settings. And here we are looking at a subset of 46 countries that are supported by Gavi. And when you look at the private market prices, if the vaccines are introduced in the private market prices for 33 of these 46 countries, the net health impact will actually turn out to be negative. On the other hand, at Gavi negotiated prices, which is like $4.50 per dose, it actually, the HPV vaccine program provides positive net health impact in most of these Gavi eligible countries. So this kind of signifies the importance of the Gavi Vaccine Alliance, which was set up in 2000, primarily to address the large-scale inequities that we have, especially between high-income countries and low-income countries with respect to affordable access to vaccines, including HPV vaccines. Next slide, please. And we can quantify the equitable impact. So one of the easier ways to understand this is if there's an equitable coverage across all different countries, then when you look on the left-hand side, those gray shadows that you see out there, they should not even exist. It should be a single diagonal line. So the larger the gray area, the larger the inequity that we see with respect to uptake of the HPV vaccine. And globally, there's roughly around a 40% inequity in how we actually have implemented HPV vaccine so far since its introduction right from 2006 up to now in 2023. But now it's 2024. And this inequities is not only global, also we can see it regionally. Also, we can see it within the same different income groups. Within low-income countries, there are inequities. Within high-income countries, again, there are inequities as well. And when you look at the slides, like with respect to the figures on the right-hand side, so the countries at the top, like for example, Tanzania, Gambia, Zimbabwe, these are the countries that will stand to gain the most by introduction of HPV vaccine. But then those are the countries that had very low coverage in the last like nearly 12 to 13 years. On the other hand, countries at the very lower with respect to like Czechoslovakia, Switzerland, these countries relatively stand to gain the less, but those have had relatively higher coverage. And the US is roughly around here with around 50% coverage right now. Relatively speaking, they have their impact by HPV vaccines in the United States is really lower because of relatively lower burden, but still they have a relatively higher coverage. Next slide, please. And moving on to one-dose vaccination. And this is work done as part of the one-dose consortium across all countries, both high-income, low-income, middle-income countries. And this was before the latest evidence on the one-dose vaccine impact was available. So some of the assumptions were quite conservative. What if we only can attain 80% efficacy instead of 2 doses? And even in that case, the impact that we see with the first dose and the marginal impact that we see with the second dose is almost 10 times the higher order. Or in essence, we need 10 times more vaccines to have the same impact with the second dose than in comparison to the first dose. But with the recent evidence that we are getting from the Kenshi trial in Kenya, the single dose is providing almost equivalent protection to that of a first dose. In this case, what we what has happened with respect to the marginal impact of the second dose is much, much lower in comparison to the impact that we can have from the single dose. And based on this evidence, the WHO Strategic Advisory, which is the global advisory body for vaccines, they are recommended to move on to a single dose vaccination. And countries including UK and Australia has already moved to actually implementing the single dose vaccination. Next slide, please. And this is a specific study where we did in context of Kenya, looking at both bivalent, quadrivalent vaccines as well as monovalent vaccine. And then what we can see in this scenario is that the current pricing for the Nola vaccine is still so much higher that currently the bivalent, quadrivalent vaccines are actually cost-effective or even cost-saving, while in the case of a monovalent vaccine, it's a little bit above the cost-effectiveness threshold. And in the case of Kenya, they're adopting the bivalent and the quadrivalent vaccine. Next slide, please. So far, we have been concerned about like the vaccine supplies are available and we are able to attain the demand, but that's not necessarily the case. So here, as we can see, 3 countries where Ireland, Denmark, and Japan, all 3 countries had enough vaccine supplies, but then the demand actually dropped because of lack of vaccine confidence. And in the case of Japan, in the last 10 years, the coverage has been actually less than 1%, even though the vaccine was still available to any adolescent girl who wanted the vaccine by just walking down to the local clinic and they can get it at no cost. But still the coverage actually went down to less than 1% because the government stopped proactive recommendation of the vaccine, which means actually they'll call the parents, they'll call the adolescent girls, and actually they'll set up an appointment to come and get the vaccine. They stopped doing it, but the clinic still had the vaccines to provide to any adolescent girl who walked in. But then because of some of the mass media or the social media, some of the events that were actually put together with respect to some of the side effects of the vaccine, which later on over investigation was proved to be not necessarily associated with the vaccines, but then still the confidence was extremely low. And finally, in the last couple of years, finally the proactive recommendation started, but still the uptake of the vaccine is still much lower, less than 30% right now. And in Japan, currently, it's a 3-dose vaccine program for the bivalent quadrivalent vaccine. And for the monovalent vaccine, it's a 2-dose vaccine program. Next slide, please. In the case of United States, when you look at the 2-dose completion coverage or those who look at the 3-dose completion, we are looking at around 52%. But when you look at the first dose completion coverage, it's around 73%. That's almost a 20% increase in absolute coverage that we can attain by just moving to a 1-dose program, which is much more logistically easy to deliver, more feasible, and also likely to have much higher confidence in the adolescent girls to take this vaccine. Next slide, please. So in summary, some of the key messages I like to basically take away is countries with higher cervical cancer burden and relatively lower or the relatively higher need for HPV vaccines so far, which many of the countries in sub-Saharan Africa have had relatively low coverage. In fact, many countries with no coverage, even though the vaccine has been available since 2006. So many of these countries in the WHO African region should be prioritized for vaccine introduction and scale-up, which is finally happening this year and in the next coming years. Most of these countries are planning to introduce the vaccine. And at Gavi negotiated prices, HPV vaccine offers positive net health benefits, including all countries in the low resource settings as well. And a single dose vaccine program is likely to much more improve affordable access and feasibility in all countries, in all income settings, from low income, middle income, and high income countries. And having vaccines alone is not useful. Social mobilization, raising public awareness, including this event that has been organized by ACS, are amazing to actually improve confidence, reduce the hesitancy, and uptake of the HPV vaccine program. And next slide, please. And these are some of the references for this work. And also thanks to all the collaborators, including the Vaccine Impact Modeling Consortium, and also to the funders. And at this point, I'll pass it on to Dr. Joel Pelowski, please.
Good morning, good afternoon. Thank you very much for the opportunity to participate in this roundtable. I'm going to be carrying on with the theme of a good news story, and going to be talking about a campaign that we call the One Less Worry campaign, which is a lovely segue from Kaj's previous comment where he talked about the importance of raising awareness, because that's precisely what this campaign is designed to do. So I'm presenting this on behalf of the HPV awareness campaign of the International Papillomavirus Society. I founded this campaign when I was president of IPVS and continued to chair the committee, but it is a large and wonderful committee from all over the world. And one of our key partners is, in fact, the Roundtable. Next slide, please. So what I'd like to do in the next few minutes is to introduce the campaign to you, tell you about some of the highlights of the campaign that we held in 2024, talk about the power of partnership, including with the Roundtable, and then give you some idea of where we're going in 2025. Next slide. So you may ask, why does public awareness matter? I think a lovely example of that was given by Paul Bloom, who said, why would a young girl get a vaccine against an infection she's never heard of? And why would parents allow their children to be vaccinated against HPV if most have never heard about the virus and don't understand the connection with cancer? Let's build awareness as a key step to improve the uptake of HPV vaccines. I think this is really true, and it is true, I think, in my own life. I've spent almost all of my life working on HPV in various capacities. And despite the fact that I never seemed to shut up about HPV with my family and friends, I was often taken aback by the lack of clarity regarding what the relationship is between HPV and the actions that many people in my family had been taking for decades, such as going to get pap smears, and in more recent years, encouraging their children or grandchildren to get the vaccination. So there seemed to be a definite lack of understanding of the virus itself. Next slide, please. So with that, the campaign was formed, and we had 4 main objectives. The first was to increase public awareness about HPV throughout the world, where the target audience was really meant to be ordinary people, the kind of people who we hope will be vaccinated and or undertake screening. We wanted to stimulate conversation about HPV to reduce stigma. One of the key factors about HPV is how common it is. Almost everybody gets it at some point in time during their lives. And we felt that if people understood that better, then there would be reduced stigma about talking about it. And that's super important, because we believe, for example, that we must do a much better job at bringing men in particular, on our side as allies for women's health care, because in far too many instances, there are situations where husbands or other male authority figures in certain settings present barriers to women getting the kind of care that they need. We want to also raise the global level of understanding of HPV, again, to help people realize that the problems that we're talking about are not unique to any one region. And then finally, with the information about HPV, with the kind of information that we've been talking about earlier, to inspire people to take the kind of actions that are now possible to reduce their risk of getting cancer. Next slide. So just to reiterate, unlike the very many excellent campaigns that are out there, which are primarily focused on a specific HPV-related disease, head and neck cancer, cervical cancer, anal cancer, this campaign is focused on the underlying virus. And that's what really makes it unique, because it allows us to cross boundaries and try and help people make connections between these different cancers and the underlying cause. Next slide, please. So again, the advantages of focusing on HPV itself is, I think, really important. That's because the level of understanding of HPV in the general population is very low. We do think that making that connection with HPV will help a light bulb go off in some people's minds about why it's important to get a vaccination against it once they've heard of it. Same thing for HPV testing, which is becoming more and more central to secondary screening. If people are being told you're going to get an HPV test now, that might be, in the absence of knowledge of HPV, more puzzling than being told that they should get a pap smear. So we hope this will help in that regard. We talked about the stigma already, and the fact that we are emphasizing that this is a really common problem. You either have it or you know someone who has it. And again, allows for people to understand the roles of males and females with the goal of reducing blame. Next slide, please. So over the years, we've experimented with different approaches to this. We're actually going into our 8th year. You can see the progression of some of our messaging. And since 2022, I think we've finally hit this sweet spot where in conjunction with many of the other very challenging things that were going on around the world, including the COVID pandemic, we decided to take a more upbeat, positive approach to the messaging, because in fact, the messaging is really promising. We have the tools to prevent many cases of cancer. And so with lots of bright colors and a tag theme of one less worry, we decided to really promote this as a good news story, if you will. Next slide, please. So the concept is that the world is an increasingly scary place. And here we have an example of something where there is something that can be done and we can take control of a problem that is serious by taking relatively simple steps to reduce that risk. And you can see that the demographics of the individuals in this slide are quite varied. We have young men, young women, people of different racial ethnic backgrounds, different colors that pop out, and different kinds of little stick figures that appeal in particular to younger people. Next slide, please. So the way this campaign is structured is we on the committee at IPVS basically provide overall direction for the campaign. And with our partners who help us develop the campaign materials, come up with videos, posters, various other forms of materials that can go into a toolkit. But the real heart of the campaign, the real work, the important work is being done by our network of over 140 partners all around the world, from ranging from NGOs to hospitals to various disease-oriented entities. The idea is we provide these materials and provide them in a way that allows them to be modified as easily as possible for the cultural context in which they're being presented. In some locations, the emphasis may be more on screening rather than vaccination, or vice versa. So it's our partner organization that really forms the heart and soul of what we do. And working with them and working with translations, we take a variety of different approaches depending on the actual geographical and cultural context. Here's an example of a poster of a young woman who's was affected by cervical cancer. And she was one of the people who had a testimonial to talk about how it affected her and encouraging women to get screened and vaccinated. Next slide, please. We also are a little bit naughty. We decided we wanted to be a bit misbehaved, and This is some unnamed members of our campaign committee who are actually putting campaign-related materials on iconic structures in the city of Edinburgh, where we will be having our HPV meeting in November, and also putting some of our campaign materials directly on sidewalks. You can see it says "One Less Worry." That was done in chalk, so a little bit of temporary graffiti. We don't think that acting up a little bit is a bad thing at all. Next slide. We have produced a campaign report, which I encourage everybody to access. You can access the report by pressing on Access the Report, and shows you how the numbers have actually changed over the years. They've gone up quite substantially, and just our hashtags alone have reached almost 100 million users, and we have another 161 million impressions from our various sites. Next slide.
Worrying about our health can weigh us down. One less worry could make our world a little lighter. What if we could eliminate one cause of cancer? Like HPV, the virus that causes 630,000 cases of cervical cancer in women and 60,000 cancer cases in men every year. Cancers that could be prevented by following 3 simple steps. Step 1. Know the facts. HPV is a virus that affects everyone, but most of us aren't even aware of it. Get educated and share what you learn with family and friends. Step 2. Vaccinate girls and boys. Vaccination can prevent almost all HPV-related cancers. Step 3. Get screened. Screening tests are essential to protect women from HPV-related cancer. By taking these 3 steps, together we can create one less worry for our world.
Thank you. That's just one example of one of our videos. Next slide, please. And then in the last year, we produced a series of very powerful testimonials from these individuals who were affected by a specific HPV-related cancer. They're animated, very colorful, and they were really well received. And I encourage you to see them if you have the opportunity. They're available at www.askabouthpv.org. Next slide, please. And then in addition to the social media, I just want to mention that we have a lot of other amazing things going on. As just one example, on the left, we had the campaign theme and posters projected in the Shibuya crossing in Tokyo one year. We've had mentions of the campaign by Emmanuel Macron and others at very high levels in government. People in hospitals are organizing seminars and classes for other clinicians, and in some parts of the world, they're organizing classes for patients, in some cases outdoors, sitting on chairs. It's really amazing the interest that people have in trying to understand more about this and the kinds of approaches that are being taken. We have Zumba classes, and we even actually have a hip hop song that has gone viral about the One Less Worry campaign, which I don't actually have time to play, but trust me, it's very fetching. Next slide. These are just, again, some examples of the many different kinds of things that are happening in China. We had activities in 14 different cities around the country, but I think one of our most recent stories that we're most proud of is in Ghana. Next slide. Where with the help of our country ambassador through the IPVS, we estimate that we reached tens of millions of people through influencers, through classes and programs throughout the country. I did want to give a special shout out to Christina and the Roundtable, one of our newest partners to the campaign. We're doing something I think really exciting right now, trying to get a program started to actually measure the direct impact of the campaign materials that I've talked about on uptake of vaccination into arms. So more to come on that in coming year or two. Next slide, please. And then for 2025, I just want to mention that we're going to be continuing this theme. We're planning on continuing our regional development of the campaign through our partners, through our IPVS country ambassadors, and we're very anxious to have new campaign partners. So if any of you are interested, please do let us know. And we do expect that the campaign will continue to grow and over time accumulate significant impact. So I think that is my last slide. If I can double check. Yep, that's just my thank you. This is an example of a little social poster that we make it easy for people to produce, to post to TikTok and tweet and Twitter and Facebook, etc. Just having a little bit of fun with it. So thanks very much for having me, and I will turn the show over to our next speaker.
Hey, thank you, Dr. Palevsky and Dr. Alves for your presentations, also for your great work on global HPV vaccination. And it's an honor to be in your company. I appreciate the invitation to talk today about the American Cancer Society's Global HPV Cancer-Free Initiative. It's an honor to speak to the members of the National HPV Vaccination Roundtable. Many of you have helped support our global prevention work over the years, and we're really appreciative of your partnership. You can go to the next slide, please. The Global HPV Cancer-Free Program is a part of the larger American Cancer Society's Global Cancer Support Team. So many of you may work with our domestic colleagues who do great work in the US on HPV vaccination and other cancer initiatives. We do have a team that focuses on across the continuum globally with a priority on low and middle income countries. You can learn more about that work at cancer.org/global. But today, next slide, I'll be talking about specifically about our global HPV cancer-free program. Our vision is to eliminate preventable cancers through high-impact cancer prevention initiatives, as I said, particularly in low and middle-income countries where the burden of cancer is the highest. And we focus interventions that are impactful and cost-effective for preventing cancer, but remain underutilized, specifically if we can help by bringing a cancer prevention lens, like in the case of HPV vaccination. Next slide. We've aligned our efforts to advance the WHO global strategy to prevent and eliminate cervical cancer as a public health problem that's already been mentioned. Most of our work to date has focused on reaching the 90% vaccination target, though we do have some work in screening as well. Next slide. The reason we focused our efforts on cervical cancer because, as you've already heard, it is preventable and treatable. It remains the fourth most common cancer among women globally. Again, the burden is much higher globally than in the US. I used to work in the domestic space, and this was very different than when you're working in the US than when you're working globally. So that's why we've focused our efforts there. And unfortunately, every 2 minutes, a woman dies of cervical cancer, which tragically could be preventable. Next slide. And few diseases, as you've already heard, reflect the global inequities as much as cervical cancer. Cervical cancer disproportionately impacts women and families in low and middle income countries. And in 2022, over 90% of deaths and incidents of cervical cancer occurred in low and middle income countries, which is why our work focuses there. And next slide. And as you've heard, and you all know, the knowledge and tools to prevent and eventually eliminate cervical cancer already exist. This is the good news. Vaccination against human papillomavirus can prevent the vast majority of cases, and combined with screening and treatment provides a path to elimination. Although vaccination against particularly high-risk types of HPV is highly effective, many girls do not have access. And as of 2020, only 30% of girls lived in countries with access to the vaccine, and less than 20% of girls globally are fully protected. We have lots of work to do. So next slide. So our program has focused on the increased demand and uptake of cervical cancer prevention services, again, specifically around HPV vaccination. We have two bodies of work. In-country work, which is currently focused in India, Kenya, and Colombia. We help facilitate collaboration among critical in-country stakeholders, which is the hope is to catalyze evidence-based action where we share resources, expertise in research, education, and communication and advocacy. And then globally, where we attempt to take the lessons learned in those countries to reach a broader audience across all lower resource and high burden countries. We work on helping create public awareness and demand for HPV vaccination as a key cancer prevention strategy, specifically mobilizing civil society organizations to work with governments to prioritize HPV vaccination as cancer prevention. And you can learn more about both our in-country work and our global work at cervicalcanceraction.org and preventglobalhpvcancers.org. And I think we'll share those in the chat too. So how do we do this? Next slide. Thank you. We use a research to action framework. So within the 3 selected countries I mentioned, India, Kenya, and Colombia, we partnered with local stakeholders. These are partners in research, civil society organizations, governments. And what we're hoping to do is add to the knowledge base on effective cervical cancer prevention interventions created in low and middle income countries. Currently, there's not a lot of evidence, like in the US, where you have a lot of interventions to choose from that have been tested and implemented and adapted in many different settings. That's not the case in many low and middle income countries. And so we're trying to add to that research. The framework is grounded in collective learning and co-creation. So we're not going it alone. We're going in with local stakeholders to field test behavioral interventions and prioritize action, and then we evaluate and establish effective tools and pathways once we've validated those interventions to help scale them up to a broader audience. Next slide. So our approach includes centering the leadership of local cancer organizations. So we look for mission alignment, organizations that have community relationships and knowledge of local health authorities, and then help pair them with behavioral research experts in their countries, and then health system stakeholders in both private and public health systems. And then these are some of our partners that we worked in different countries on the work that I'll walk through. Next slide, please. So across all 3 countries, and as you've if you work in the US, you already know, we have found that healthcare provider recommendations matter. So the strategic partners in all 3 countries, they work to develop a shared understanding of what was the barriers and facilitators to increasing HPV vaccination. So this was done in each country, but during the same time period. So they had separate work going on, but they came to some of the same conclusions. So healthcare professionals, including physicians and community health workers, emerged as credible sources to help influence parents and caregivers who are the ones who are making the decisions about vaccinating adolescents. These healthcare workers were prioritized for interventions where we could influence these healthcare providers to then influence parents. So that's kind of the process. And the next slide. So we took the formative research done by the in-country partners, and then we tested interventions. And then the interventions that were found to be the most effective were packaged into action guides with complementary resources. So trying to take that initial research, test it out, and then package it into something that can be used across the country by different partners. Next slide. So we have found 3 different pathways in the different countries. So in India, the interventions we did were aimed at physicians, and they were developed in partnership with national medical societies, FOGSI, which is the Federation of Obstetric and Gynecological Societies of India, and IAP, the Indian Academy of Pediatrics, and our local partners, the Cancer Foundation of India. And the focus has been on the private sector since HPV is not yet included in their national immunization program. So all vaccines are paid out of pocket. And so we partnered with these medical societies to reach physicians. And then in Kenya, HPV is included in their national immunization program, but the rates remain below the national target. And so community health workers who are attached to local health facilities were identified as the best avenue to reach parents to eventually reach adolescents and vaccinate. And so that was the pathway chosen in Kenya. And in Colombia, HPV, again, was part of the national immunization program, and the rates rose actually really quickly. Then they fell sharply after there was an incident that was incorrectly connected to HPV vaccination. So they're working to recover those rates. And they have excellent electronic health records. So in Colombia, we've actually worked through central health authorities and health insurance plans, and they are able to directly send messages to parents, SMS messages or text messages, and specifically to parents that had not yet vaccinated their children. So those are the 3 pathways in the 3 countries that were chosen. Next slide. So on the side, you can see this is a picture of the toolkit. And I think when the slides are shared later, all these resources will be linked. But these are resources for medical societies to activate their members. And in partnership with the two medical societies I've mentioned, they've already trained over 10,000 member physicians on the burden of cervical cancer, the role that physicians play in recommending vaccination, and how to answer parental questions, and then activating those same physicians to be cancer prevention champions within their communities. Next slide. So this is the guide for Kenya and the resources that were developed there. In Kenya, civil society, 3 cancer civil society organization partners have led work. They've worked in 5 counties, and so far they've reached 26 health facilities. This work is ongoing, and they've trained over 180 community health promoters, and those are otherwise known as like community health workers here in the US. So they've been trained and starting to go reach parents in their homes for girls who are not yet vaccinated. Next slide. And then in Colombia, all the work was done in Spanish, but has also been translated to English. So there is a messaging guide that was developed. So SMS text messages were developed and then tested, and then they've been sent to over 174,000 parents that had not yet vaccinated their parents. And so then the messages that worked best were packaged into these toolkits, both in English and Spanish. And now it's very exciting that those toolkits are now being used by local health authorities and health insurance companies to message to their members. And that work is ongoing as well. Next slide. So all of our resources are available, even though they were developed for their specific countries. They're available free and online. And you can find it on preventglobalhpvcancers.org, and we hope you visit there. All the original research, I know I just kind of skimmed over it, is available, the original research reports along with all the tools. Next slide. Great. So that was, I already went over our deep kind of 3-country work where we developed the individual toolkits. Well, we try to disseminate best practices and lessons learned from those countries more broadly across other low and lower resource countries. And that we do that through a partnership with Cancer Research UK. We co-chair a network called the Cervical Cancer Action for Elimination Network. And we host a series of virtual and in-person dialogues on issues that are critical for cervical cancer elimination. And we've really focused on HPV vaccination. So all the reports from the previous dialogues are available on cervicalcanceraction.org. And if you're interested at all in learning more about the work we have going on or joining a future dialogue, please email us, ccaenetwork@cancer.org. We'd love to have you join us. And I think, yep, one more. These are pictures of some of our amazing partners in Colombia, Kenya, India, who do the work on the ground. They are amazing and couldn't do this work without them. So wanted to give a shout out to them. And then last but not least, our final slide is the rest of the global team who I'm presenting on behalf of, and our in-country consultants. So just wanted to give a shout out to them. We could not do this work without them. And thank you for letting me share a little bit about our global cancer-free program and your interest in that. And I'll hand it over to Gabby.
Awesome. So thank you guys. Thank you to all of our wonderful presenters today. I don't know about you guys, but I learned a great deal of information. And so we're now going to be transitioning into the Q&A portion of our webinar for today, our last 10-year celebration day on Global. So if you have any questions, please go ahead and drop those questions in the chat. And so I will go ahead and just ask a question of all of our presenters. And I hope for today, using first names is going to be Kay. So I'm going to say Joel, Kaja, and Sarah. We're just going to have a brief discussion and conversation. So great presentation today on a lot of the work that you've seen and done globally and internationally, and its influence or possible influence on what we can use here globally in the United States. So I'm going to ask the question, what strategies have you seen globally that we can increase more of in the US? And so I'm going to first ask Kaja.
I mean, like what we need is like one with respect to the delivery mechanism. One is through schools, the other is through clinics. And when we do it through schools, we need to have a good partnership between the health between the health sector and as well as the education sector, both at the very local level and as well as at the higher levels as well. So wherein if school nurses are providing, they are also educated on the awareness of the benefits of the vaccine as well. And these benefits are basically communicated not only to the students, but also to the parents as well, to make sure that they understand that this vaccine is safe, effective, and it's beneficial for both girls and as well as boys as well. Both direct benefits and as well as also there's an indirect benefit even to non-vaccinated children as well because of the reduction in transmission as well. So as long as we communicate the benefits well and involve all the stakeholders in risk communication, social mobilization, that'd be much more helpful rather than just providing the vaccine. Yeah, thank you.
Awesome. So I think I heard school-based, clinic-based, communication through some of those avenues to all children, boys and girls, and also just socializing and mobilizing through some of that on-time communication, full communication, and the benefits beyond just the individual being vaccinated. Is that correct, Kaja?
Yeah, that's a very good summary.
Awesome. I'm so glad I got it all. Joel, what do you think are some strategies? And I think I have an idea what you're going to say, because I know all of the amazing work that you guys do. But what do you think we should do more of?
Well, one of the things, I think I'm not going to say what I think you think I'm going to say, which is I've been impressed with some of the efforts of Xavier Bosch and others who've been pushing HPV faster, where the idea is to try and couple screening with vaccination, both for women who qualify for both at the same time, but also for moms to bring in their daughters or their sons in this case. Again, linking everybody together with respect to risk of HPV, saying, look, mommy is getting vaccinated or getting screened to help protect against this, and you can do this too. It's like becomes like a family activity.
Yeah.
And I think that to me sends a lot of positive messages. We're taking care of each other and doing things transgenerationally. I also want to echo the importance of school-based vaccination programs, which have been so effective in the international setting, and where, because of, again, the way, not just our healthcare system being quite fragmented, but our public education system is quite fragmented. It would be really nice if we could figure out a way of being more inserted into a healthcare setting, into a public education setting, rather.
Yeah, I think that's really good. And yes, you did shock me. I thought he was going to answer that differently, but I do like the idea of the parent-child dyad. And like you said, the family, setting the family dynamics, reducing maybe some hesitancy, setting some new social norms for generations to continue in those positive behaviors and the role modeling of those behaviors. So I think you both bring some really good points of like how we can maybe adapt some of what's being done internationally and globally into what we need to think more about how we can use schools. So Sarah, I saw you nod. But I'm not going to assume. What do you think we should do more of when we look at the U.S. and what we've learned globally?
Well, you get the trifecta for school-based vaccination for me. So that if available, vaccinating through schools for sure. And I do think that focusing on, and I know this is happening in the US, but really focusing on the cancer prevention aspect of the vaccine. So again, just kind of preaching to the choir here. But and then I think, again, maybe this will get a little more detailed, but like when you can't have school-based vaccination and you're focusing on a specific population, really going to those community leaders who are influential with that community. So after you already have your healthcare workers on board, at least that's what we've seen effective, is that going to those influential leaders and kind of doing some education with them one-on-one, but then that's a one-to-many approach. Once they're on board, you can get the community on board.
And I'm glad you brought that up because I think you did a good introduction segue to more of how we think about it from the vaccination equity perspective. And we see a lot of those different type of strategies, community-based, engaged, going to those thought leaders, those trusted messengers, and maybe some hard to reach populations or populations where vaccination may not be higher or as high as we would like to see it. So I'm going to add on to that first question and ask specifically to advancing HPV vaccination equity. What would you like to see implemented from like what we've learned from globally? So it's kind of taking the first question a step further. Do you think that school-based is still one of the top strategy or priority, or do you think there's some other avenues and best practices that we can take to also address some of the vaccination equity challenges that have been presented in the United States? So I'll go first to Joel.
Well, I still think the school-based approach is the best, but it's obviously not working optimally in every place. I think a fail-safe or approach to that is to emphasize more the importance of gender-neutral vaccination, because boys and girls get vaccinated potentially in different settings, yet still provide some degree of cross-herd protection. So I think even if we're not able to vaccinate as many boys and girls in a public school setting, if we at least emphasize the importance of gender-neutral vaccination, I think we would reduce the inequities in that given population.
Okay, thank you, Sarah. I'm switching the order up, so you got to be ready at all times. Okay.
Agree with the school. Again, gonna double down on that. I do think, especially globally and in different countries with different resources, that gender neutral is difficult sometimes because, I mean, the burden it lies on females through cervical cancer. And so I think it's just like a fine line between making sure that we address the cancer burden, but sometimes, yeah, when you go in with a female only approach, then it raises more issues, if that makes sense. So it's a very nuanced discussion, and I don't know how we tackle it. But the other thing I did forget to mention is where available, again, like our work in Colombia, we've seen great focused work when you have good electronic health records, or you have health insurance companies or ministries of health where you have great data. And so being able to do tailored messaging to specific populations. So I think being able to reach them where, if you know they haven't been vaccinated, if you know the language of origin of the family, and you can give them, here's where you get vaccinated and when. So like giving them very specific information. So that would be another way to go on the kind of technology route of being able to reach people literally where they are.
Okay. So tailoring also to like not just access, but just the country's capacity, right? So some of the things that they may have available or not have available, and using that to tweak your approach and how you address, right?
Well, applying to the US, I mean, we still have lots of people of different languages, backgrounds. And so if you can tailor, it's really hard to do on a large scale, but if you could do it through technology, being able to tailor the message, the image, the information, if that makes sense. So I think being able to do that, you can reach people with the message that they need when they need it.
Awesome. Kaja.
So in general, like country level policy making for vaccines is done by the National Immunization Technical Advisory Groups. So in the US, it's the Advisory Committee for Immunization Practices. So one immediate way in which we can actually improve equity is to seriously consider a single dose vaccination strategy. Currently, for a 2-dose and 3-dose completion rates, it's roughly around 50%. But with just the first dose completion rate is around 73% right now in the US. So that could be something, if the ACIP does recommend, which many other NITACs have recommended in other countries, then it might be possible to, it'd be much more relatively logistically easier to implement a single dose strategy rather than a 2-dose or a 3-dose strategy. Yeah, thank you.
Yeah. No problem. And I know we had a question about the 1 dose or indications of a 1 dose. And so currently the CDC ACIP is currently reviewing the data and the evidence to support that. But I know, Sarah, you had pointed out some resources that people can kind of go too and look to see more information on what's been done. Am I correct with that?
Yep, I'll put that in the chat. It kind of outlines like the pros and cons of single dose and things that countries need to consider. But again, yeah, that's decided at the country level, but I'll drop that in the chat.
Awesome. And thank you, Kaja, for that. I mean, you're presenting some of what you've seen done globally in that space and some of the improved vaccination rates. And so what can it look like for the US if ACIP does move towards one dose? So the third question I have for you is, one of the things that I think I got a lot from the three presentations is the role of partnerships and collaboration, but also innovative approaches, like how you innovatively made those connections in the countries to then partner and move the needle forward. So can you speak more to the formal and informal connections that you've made in some of those countries and how that's helped drive innovation or just drive progress forward? So Joel, I'll start with you.
So in our case, since we work in such an enormously divergent set of populations and cultures, languages, it's got to be done at the local level to begin with. And I think although our approach to giving people materials, say for the campaign, is to provide them with a template, it really is meant to be as easily modifiable as possible. So the structure of the materials needs to be determined really by the people on the ground, by the communities in question. And there are many, many communities in question for a given area, because the people who focus more, say, on vaccination of young women are going to be thinking about this differently from people who are trying to improve uptake of screening, in older women. So it really is a very microclimate oriented approach. And I think the best way to do that is to start with people who are on the ground dealing with those issues and interact very intensively and really start from their perspective. In IPVS, we started this program called the Country Ambassador Program, which takes younger IPVS members and asks them to sort of be a liaison between their local communities and IPVS, because they understand our mindset too. So having those kind of interactions at the local level and with the society and with committees run by the society, I think is super helpful.
Okay. I was going to ask you, this year, your One Less Worry campaign was able to feature, survivors and from a variety of different countries. And so the thought is, how did you even identify? So that was going to be how were you able to identify those individuals to lend their voice to the campaign,
They were recommended by our local partners. They were the people who had been dealing with these problems. We wouldn't have known them. So they knew who was articulate, who was connecting with the local community. Many of the people in these videos were actually activists now that they've survived their illness. That's a great example of how local connections really make a big difference.
Awesome. Kaj, I'm going to ask you the same question, formal and informal connections. How can we continue to grow that, and what have you done in the past to help in this area of work?
One aspect is that when a vaccine is introduced, we need to have a vaccine adverse event reporting system that can rapidly investigate any side effects that may be reported before we have a media outcry on those incidents. And this has happened so I'm currently in Kazakhstan, where this has happened around 8 years before as well, when the vaccine was introduced through a pilot program. In India as well, around 10 years before it went through a pilot program, and there were a couple of girls who actually died as well. But these were more associated with respect to timing, but they're not caused by the vaccines. But by the time the investigations were done and by the time the reporting came into place, the large media outcry already basically reduced the confidence in the vaccine programs, and programs both in like Kazakhstan, India, as well as in Japan basically failed, and the uptake is basically practically like almost close to zero. So we need to have if there are events, any adverse events that are reported, they need to be investigated and communicated very transparently. And even if it happens to be a real side effect caused by the vaccine, that needs to be communicated. Or if it is only associated in timing but not caused by the vaccine, that also needs to be communicated in a timely manner. Yeah, thank you.
I do want to follow up on something that you included in your presentation. You talked about the Gavi, also Vaccine Alliance. And can you speak more to their role and how they help? Because we also know that internationally or globally, in the US, we use the Gardasil 9. In some countries, they still use some of the 4-valent or the bivalent. And can you talk to more so about Gavi's role in helping bridge the gap in some of those formal connections that we have?
Yeah. So when the vaccine was initially introduced in the US, single dose cost around $120 per dose. And at that particular cost and pricing is just not affordable in many low resource settings. So in the case of Gavi, basically they negotiated prices where it costs $4.50 per dose. And at that prices, wherein it's a kind of a block, as a block it's been purchased, it turns out to be a cost-effective option for many of the countries that are currently supported by Gavi. And these are countries that the Gavi eligible countries, their GDP threshold is like less than $2,000 per year. And those are the countries for which a $120 per dose vaccine is just not, it's well beyond their healthcare budget. Yeah.
Okay, awesome. So my last question is going to be more as a follow-up for Sarah. Specifically, you worked in India, Kenya, and Colombia. Why those 3 countries of focus for the global work in HPV vaccination?
Good question. That was selected before my time, but I can tell you the selection process, which was at the time, ACS, this is year 5, maybe 7 years ago, did an assessment on where they were looking for high impact countries that were influential in their regions. So look with India, Kenya, Colombia, looking for 3 different WHO regions, and that had we're in 3 different stages of vaccine rollout. So India had not yet introduced HPV vaccine. Kenya had, Colombia had, like I had said, had increased their vaccination rates and then they decreased. So basically trying to find different opportunities where the 3 countries didn't look the same, if that makes sense. Not only could they make the impact in their countries with vaccine rates, but also they could be influential within their own regions. Or like in the case of Colombia, like they have really great EHRs. Not every country has that. And so we wouldn't want to have 3 examples of like all that. So basically we're looking for 3 case studies that could be, useful in the country, but also applicable to other countries. So hopefully are achieving that, but that was the goal originally.
And have the partnerships or connections been different in all 3? I know you obviously have an in-country partner that you work with, but has the process been the same, or has there been some adaptations to, where the country is and how to move that forward?
Great question. So it's been similar in that they all started out with a local cancer organization and a behavioral researcher. So it was that was the original kind of criteria, but then they've all evolved. So in India, where we've really worked to engage those national medical societies, which is amazing. They each have 40,000 members. It's just like such a huge reach. Whereas in Colombia, because of the pandemic, I had originally wanted to go through ministries of health. Things, they of course focused on COVID as they should have. And so we pivoted to working with health insurance companies who had the same access to EHRs and be able to, so that's slightly pivoted, but we still have our original civil society organization there, La Liga. And now those ministries, now that they have more capacity, have now come back in and are using the messages. So it's kind of evolved over time. And in Kenya, it's really exciting. We started with 1 cancer civil society organization, and now they've added 2 more. And we're one of the partners in Kenya actually is a secretariat for a Africa-wide coalition that is newly developed around cervical cancer elimination. And so we're hoping to help share some of the best practices that come out of Kenya with the other countries in Africa through those connections. So they each evolved, but still have those same cancer organizations and then continue to add partners. So
awesome. So last question, just because I also am very interested and I know a little bit about it. Joel, one of the questions is, do you know what's the reach for your campaign for Indigenous communities around the world? I also know that you track some of the metrics of your campaign. And specifically, she's asking because it's a disproportionate impact, right, of the cancers. So what do you guys do to track, the impact of your campaign?
Yeah, it's a great question, and it's it's an evolving area. It's an extremely important thing, one of the most challenging things that we have to do. So I'd have to say, unfortunately, we don't have a lot of information right now on impact in Indigenous communities or really very many other communities. What we know is how many people we have potentially reached, how many people have clicked on something or seen or heard something, but we don't really know how much time they're spending on it, for example, and what the downstream effect is in terms of increasing the likelihood that they will take some sort of an action. These are things that we're moving more towards in partnership with the Roundtable, actually, to try and get a handle on. Very, very challenging thing to do, actually. Very important, but very challenging.
Yeah, I think that's one of the things it's hard to determine actual behavior sometimes in the communication strategies, but you would hope, and we hope that we will get to that point where we can kind of determine the next steps of where people are going. So I want to say thank you to Joel, Kaja, and Sarah. It's been a great conversation learning more about you and the work that you're doing within the respective organizations and how you're really not just moving the needle forward with HPV vaccination globally, but also moving the needle forward with how we can learn from global efforts and improve vaccination efforts in the US. As a fellow global citizen from the Bahamas, I love just learning and soaking all of this information from each of you. I hope that this is not the last that we get to engage with you guys and learning more about the amazing work. We know, Joel, you're stuck with us with the campaign, and Kaja, we look forward to continuing to learn more about the work that you're doing. And Sarah, you're at ACS, so we're going to see you always, right? So I want to thank you and move forward into our after party and wrap up celebration. It's the last after party for this week, but we hope that you've enjoyed the sessions as well as the presentations. And I'm going to just move forward and talking about some key highlights and some key information. So talking about global, as you know, we are leading the effort in identifying a national elimination plan for the US, starting with cervical cancer. So the World Health Organization has identified a 90-70-90 goal. We at the US are proposing a 90-90 goal, which is 90% vaccination, 90% screening, and 90% diagnosis to treatment. And we are not alone. We are excited that we get to partner with the National Roundtable on Cervical Cancer to lead this effort. So be on the lookout for more information. Next slide. So Sarah has dropped the link in the chat, and I believe our chat masters have also dropped the link. If you want to learn more about the amazing work that they've done, as well as some of the resources and tools, such as the reports and action guides, please visit the Prevent Global HPV Cancers website to learn more and to access some of those free resources. Next slide. As always, we love to update our resource center with timely information. Some of what Sarah has shared and some of our other global partners have shared have also been updated and uploaded to our resource center. So please visit our website and learn more. Next slide. And join us, follow us, engage with us. We are all on social media. We love to put out timely information about new resources, new tools, and new webinars, as well as education opportunities, especially also in the global space. So feel free to follow us if you have not done so already. Also, you want to follow and see the after party of what the 10-year celebration will look like. So we look forward to having you join us on our social media channels. Next slide. Our newsletter, if you have not signed up, you are missing out. So please go ahead, go to our website, scroll all the way at the bottom, and sign up for our listserv to be on the know or in the know about HPV Roundtable happenings, new information, new opportunities that may come up from month to month. We'd like to keep our members and our general audience members involved and informed. So we look forward to having you sign up as well. Next slide. Special thank you to our National Meeting Planning Committee. Special kudos to Tina Turpin of the ACS HPV Vaccination Roundtable for leading and supporting this work, as well as our volunteers from our amazing organizations, all of whom are on this slide. We could not have had such a great party without you guys. And last but not least, please, 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 this is the survey that will evaluate the entire week. So if you have not done any of the surveys for any of the other days, that is fine. We need you to complete this survey and give us feedback on the entire week of the party, how well we did, and what areas we can improve. We look forward to getting your feedback and hope you guys have a blessed remainder of your Friday. Thank you so much and have a great weekend.